So it's, yeah, Dr. Aisha, please start.
Can I start?
Yes.
Start the presentation?
Yes, your YouTube live, Doctor.
Assalamu alaikum, everyone. This is Dr. Aisha. I thank the GDP group for giving me the opportunity to host today's program. So before we exactly start the topic and consider exactly what the presentation is.
The presentation. Yes, your YouTube live, Doctor.
So we come across a lot of words in our dental practice, like palliative patients, palliative cares, and etc. So let me just give a little light of what exactly the palliative care is. So palliative care is basically a specialized medical treatment which is given to the people who are seriously ill. We basically point at exactly to relieve the stresses and also the symptoms what the patients exactly go through. So the main goal of our palliative care would be providing a quality life to the patient and both to the family. So, as patient is already ill and also undergoing a lot of treatments for the same specialist for the same illness what the patient has been having, what exactly we do is we it involves any of the systems of the body. But here, as we are talking about the oral cavity, let me present a brief explanation of what exactly is happening. So, this is the oral cavity what we exactly go for. But when the patients are seriously ill, we see a lot of in illness and sort of exactly like leukemias, cancer of the oral cavity, that is can be the buccal mucosa, the cancer of the tongue. The cancers can be involving the buccal mucosa again, which is having a problem, and also like it involves the anterior buccal mucosa, etc. So what exactly are we looking at? What are we trying to do in these patients? So the main goal of us has to be restoring the function and also the aesthetics. So when we try to exactly restore the patients, that is either to the function and the aesthetics, that is the main criteria, what exactly are we going to do? We do this either through surgical procedures, it can involve the chemotherapy, it can involve the radiation therapy. But though we involve all these treatments in our practice for the patients to restore, we see a lot of side effects along with the treatments itself, which can be because of the illness, or also it can also be because of the adverse effects which is going to involve. Like if you can see, there can be acute side effects or the chronic side effects. Acute side effects, it basically involves after the radiation therapy will be glossitis, that is inflammation of the oral mucosa, which you can see here. And then we have partial or the complete loss of the taste sensations, or it can also be the xerostomia. Now, chronic side effects of the radiation therapy would involve like radiation induced, that is the dental caries. It can involve involve the candidiasis, or it can be osteoradionecrosis. So side effects, few which is going to be after chemotherapy would be the necrosis of the tongue. Again, the osteoid necrosis of the oral cavity, that's going to be the gums or the alveolus tissue. And then we also have some of the periodontal problems which can come up. So now what exactly are we seeing? Those are the symptoms like dysphagia, dry mouth, altered sensations, and halitosis or etc. Now, when we come to exactly the multidisciplinary approach, wherein we have a team of approach what exactly the patient has to go on. So it can be a generalized team or a specialized team. It can be involving the general physician, it can involve the physiotherapist, psychologist, psychiatrist, etc. But if you can see in this particular slide, we hardly see the dentist involving in this particular slide. So when unless and until we have oral cavity coming up, the dentist will not be just completely ignored for the treatment. So today we have Dr. Aswaf Ahsan, who is going to guide us on the topic, give us light on the topic, the oral problems and the dental issues about the palliative patients. Sir is a professor and head of the ICRA Hospital, that is in Kozhikode. It's been there since 2010. Sir was also a faculty for about 25 years and also the head at the KMCT Dental College for about 9 years. Then Sir is also involved in the Dentist and You, that's a charitable foundation that is basically giving the patients, the underprivileged patients, the dental aid for their particular treatment, or it also involves patients like palliative volunteers for the patients, and also an opportunity for the patients or the doctors who can give treatment for these patients. This is also a This is also a charitable trust wherein it involves the uh, conducting programs for the school dental camps or the charitable institutional camps, and also mobile dental cares for the patients. Sir is also the managing director, editor of the 100 book old publisher South Indian Alton History. Is also the Dental Health Science Journal reviewer from 2000 to the present year. Is also the chairman of the Photonics Imaging Solution and also team leader at the Red Cross and the Red Crescent Disaster Relief. Sir is also having about 39 publications, which includes the oral studies, the case reports, and also the review articles. A few have been mentioned here. That is submental intubation or also the subdistal speech outcomes in the left lip and the cleft palate patients. A few of the case reports, which includes an intra or disseminated intracoagulation of the sublingual hematoma and also anatomical variations in developing the mandibular nerve canals. So with this presentation on a brief note, I now request Dr. Aswaf Ahsan, sir, to please share his immense knowledge on the topic. Over to you, sir.
Hello, good evening. I hope I'm audible. Am
Yes.
I? Am I? Yes? Am I
Yes,
audible? Right. So I'll first let me, yes, share the screen so that, yes. Hope the screen is shared. It's visible. Hello? Yes?
Yes, sir.
Yes. That's fine. Thank you, Aisha, for nice words and the profuse kind of introduction. Thank you so much. First, let me tell you that I'm trying to handle an issue in which I should say that our involvement, mental stability and involvement should be minimal when we deal with the matters. But I should tell you this because my uncle passed away just 1 hour before. I was there, and I had to rush back to present this because I am communicating with this group for the past maybe over a year, and my procrastination went on for many reasons. But rather, I should admit that it was my problem, but they persistently asked me to present this. More than presentations, I thought I will discuss with you about oral problems in palliative care, because we have been doing this in and around Calicut for the past 14 years or so. And that experience, I will just try to share with you as an opening presentation. My goal of presenting this is, first thing is to share our experiences with you, one. Number two is to improve the network of people who are trying to do for palliative patients, those who require this kind of attention and treatment. So these are the major things I'm aiming at, rather than giving you bookish kind of information, which you all know much better than me, because I'm a retired professor who 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 find answers for many questions. All right. So let me get into the topic. the issue is, the first problem which we face is we have this. Okay, you are seeing the screen. We have a big number of dentists, along with Mexico and Brazil, maybe. In the world, these three countries are leading for number of dentists. We have so many. And in Kerala, as they say, according to 2014 census, as of 2020 also, I mean, the ratio is 1 to less than 4,000. That is 3,300 odd. So it should be 3,000 already. So every year, 23,000 plus fresh graduates are qualifying. But still, treatment is not reaching to everybody, or at least many of them. So this irony, there is a structural problem somewhere that we have to address. Maybe those who can pay, and like OOP we call, right, out of the pocket payment, they can get treated if they they can be ambulated to, or they can walk upstairs and go to a clinic and get them proper treatment by paying them, or insurance part if they are insured. But most of dental therapy or treatment modalities are not included in insurance schemes, so they don't get. Even those who can pay out of the pocket, or they get partly insured, is difficult to get it insured. I mean, many other medical treatments we are getting insurance coverage, because medical health insurance is coming in a big way to India now. That is part of the politics anyway. So dentistry, as such, we have enough hands, at least somewhere near, but these trained hands are not getting opportunities to treat people because of many reasons. And also people are not getting proper care for these reasons and other reasons. And that is out of the purview of this presentation. That is the politics of health, which we should discuss on another day, probably, or you should bring an expert and make him or her talk on this. So this is one thing which we should keep in mind when we think of palliative patients, because mostly terminally ill cases or malignancy affected patients, or pediatric cases, or such cases, productivity, quote unquote, is not found by others. So they don't care. We say, right, in our places, in our urban areas also, an elderly man cannot walk into a bus, for example. If we have public transport system also. I met a very popular journalist who was working in the Hindu in Chennai when I went for a book release function. And then I was talking to him. His name is BRP Bhaskar. He passed away recently. He was 90 plus and staying in Chennai. Then I asked him, why are you not coming back to Kerala? Then he said, Kerala is not geriatric friendly. Then I asked him why. He said, look, seats are booked in buses, like for geriatric people. But to enter the bus, you need to do many acrobatics and get the seat. You can't reach to the seat to sit there. This is a structural issue. Like, you have a bus, you have public transport in place, but still you are not able to sit there. Am I audible?
Yes, sir.
Yeah, fine. If there is any problem, please let me know. I mean, I will just go on. So similarly, there are issues which will prevent treatment from reaching patients. That is what I said. So in palliative care, particularly in palliative care, they're either bedridden, or they are terminally ill and they are not able to do any job. Such people, it becomes even more difficult to get treatment for such people. And also, most of the time, we believe patients should come to us always. we can't go to them, right? How can we go to them? Even for diagnosis, we are not prepared. Now, luckily, we have video conferencing, if at all, patient can have. Most of the people have data, and then using phone, they can. If they have a smartphone, of course, they can communicate with us and see whether this patient needs treatment or not. And then we can cut short one visit to the patient and all that. I will come to that later. So 70% of the dentists are practicing in cities, and only 30% are for the semi-urban and rural population. Out of 1,17,000, the numbers you can see there, a chunk of dentists, a major chunk of the dentists are from Andhra Pradesh. One second. Just a minute. So one second. Okay, so a major chunk are from the such cities. So we are in the sense that northern India, we have less number of dental colleges, dental schools, and dental dentists. So these people are again, they won't get access to treatment and so on and so forth. So basically, we have enough hands, but we don't get treatment reach to them, or they don't have access to reach us, the trained one. Now, coming to a case which I would like to show you is this patient. Every photographs which we show here are, we have taken consent from patients, and during procedures, we have taken these photographs only for educational purposes. So this patient, this person had issues. He is hemiplegic also, and he is unable to go. He's a fisherman of 60 odd years. He just needed one extraction to be done. So simple. But how can he reach a clinic? In the second part of the picture, you are seeing Dr. Vivek, who is also listening to this. He was partly involved in preparing this presentation. He's standing there, and then the procedure was done. The person was so happy, not because the procedure was done. There comes the issue actually. They were happy that people went there to meet them and address their issue and do what they required. But getting the treatment done was a second issue. In fact, they were more happy that people are visiting them and helping them out. So here, a question is like a very popular book, Illness as Metaphor. I remember this book very often, written by Susan Sontag. Susan Sontag writes this keeping tuberculosis in mind and also cancer in mind. And then later, an extended version came when HIV came in. But she did not write. She could not write about our corona issue. What I'm trying to say is, cancer or such a disease, when it affects a person, then the person goes for a metamorphosis actually, because people are seeing him or her with a different kind of attitude, we can say, or an approach, we can say. And that disease has become a metaphor now. It is no more a disease. So we go with a lot of sympathy, and we look at them as though they are going to die next day. And we look at them with a lot of, those kind of feelings, which you all know. So Susan writes about this. She says illness as a metaphor. So they are lying down there. They can't move out. Their entertainments are limited. So what I'm trying to say, another person, a lady, who I always remember, that she asked us, or our daughter requested us to go for an extraction of a couple of maxillary teeth. When we went there, the whole maxilla was moving. We saw it was a carcinoma case, advanced carcinoma case. So we decided not to go for extraction because there was no question of extraction. If you try to extract, the whole maxilla will come out. So we started visiting them. We always follow a protocol that we don't take anything from any food from them, because they all are very big-hearted mostly, and they will provide everything for us. But we don't usually take anything from there. But she forced us, and we used to visit her. When she expired, after some time, a sweet lady of in her early 80s. Her son came to our clinic then in the hospital, and then son came with her ornaments and then gave it to us and said that my mom said that it should be given for this association. We said we don't accept such things. If you want to, you can donate some money and then go. But this are having some emotional values. What I'm trying to say is this becomes a metaphor, and this person goes for a metamorphosis, and the person really want you to behave with them or him or her in an ordinary fashion. But we see them only as a cancer patient. Even after it's cured, we say that we call them as cancer survivor. I hope what I'm trying to say, it was said by Susan Sontag in a whole book, so it is difficult to convey in a few sentences. But I think you have got that message. She says that you need to just come. That is the message. We need to be there. We need to visit them, and that is more important than the treatment part of it. That is what we understood from this. And the second case, she was younger, in her 40s. She was worried about her aesthetics part also. You can see she was quadriplegic, completely bedridden. She can't move, but she wanted a denture. So this is Khairunisa. Khairunisa is our healthcare provider. She helps us around. There are many. So we are preparing a denture for her. This was prepared for her. And here, as dentists, the problem is we discuss about 9 o'clock position, we discuss about 11 o'clock position, and how to sit and how not to break our back and all that. But here there is no position at all. Patient is in a position, person is in a position, and then you have to adjust with your back, whichever position you were able to do. You do standing dentistry. You do sometimes. I still remember after tsunami, when she read that, I remember that as a part of the Red Cross team, I had been to Indonesia. The part is called Aceh, Banda Aceh, where the whole set of doctors were washed away because doctors' meeting was going on. Their annual meeting was going on in the beach, and tsunami took almost all the doctors of that region. They were all missing. In all primary health centers where we went, doctors were missing. So it was a national disaster there. So when we went to treat dental patients there were we had no instrumentations. So orthopedic instruments we used, and we had to warlike conditions, we had to do the treatment. So here in these cases, sometimes textbook fashion, the treatment plan can't be in a textbook fashion. So you have to sit, decide, discuss, do many things, and then finally try to deliver them what they really are wishing to. So this is the only way we can, make them. We think of only making them happy, as I should earlier mentioned, the aesthetics, their food intake, of function. All these we have to keep in mind. Of course, that is right. But sometimes patients or the persons will ask us to go for extraction of anteriors because they are not able to consume food. Sometimes they'll ask, they want a denture like this, even if it is difficult for them to feed on. So these are the issues which we address. We are forced to address sometimes, but then again we see we can see this malignant issues, malignant disorders are 28 or 29%. Rest, you have a plethora of conditions, an array of diseases where you have to consider them for palliative care. Simply a person, last evening, I met him on the road, and he told me, because of sciatica, I am not able to go to a dental clinic. I asked him, what is the relation between sciatica and dental clinic? Then he said, I can't walk and go because I can't, it is paining me, hurting me. I can't walk upstairs. Most of the clinics here are in the first floor. So what I'm trying to say is, malignant conditions are, yes, of course, there are malignant diseases. I mean, malignant neoplasms, and such patients are coming to us for treatment. But there are many more they require our support. About statistics, we'll tell you about 2.5 million live with cancer in India. More than 80% of them are incurable because it is not diagnosed earlier on. Approximately 2.5 million again with HIV, and combined with other diseases, 5.5 million need palliative care. In Calicut city itself, around 1,500 to 2,000 people need care, home-based care. So, I mean, home care, we call it. Less than 1% has access to palliative care. So, states like Kerala, Karnataka, Tamil Nadu, Maharashtra, Telangana might have better infrastructure, but including Kerala also. Other states, even in these states, just excuse me 1 second. Even in other states like Kerala, Karnataka, I mean, the states which I have mentioned, Kerala, Karnataka, Tamil Nadu, and Telangana, there too you have issues getting treatment, because you can't, like you say, in India, we have this many dentists. Does that make sense, actually? We had been to UP, that is Kandla, and then we saw dental care is a taboo mostly. I mean, they don't get, most of the dentists are quacks there. So, I'm not complaining about it, but we say India, but it's not uniform. We say Kerala, and even urban areas in Kerala, even though Kerala has got no villages, the whole Kerala is a town, but still, patients, there are, thousands of patients who are not willing to walk into a dental clinic. And then forget about palliative care. Palliative care is entirely, it's second or third stage. You need to see this. So less than 1% have access to palliative care here. So this is my point. And now, older concept was you go to a doctor, get a curative care, then suppose you don't have anything left, then you go for palliative care and wait for death. Waiting for death was, palliative care was a sign for waiting for death. But now it has changed. So disease modifying or potentially curative care is going on one side, whereas supportive and palliative care will go on the other side. And supportive and palliative care will increase as the age advances. And it goes on. And it reaches death. Death is an inevitable reality which we have to accept. And the more you accept death, the life becomes creative. Otherwise, life is not creative. If there is no death, like Saramago, Joe Saramago has written a novel, Death at Intervals. If you read that, you can understand. Death suddenly stops in a town. Nobody dies. Then what happens? You read that novel and get back to me. I'll be happy. Joe Saramago's Death at Intervals, if those who are reading fiction can go for it. So he says, similarly here, we have to accept death. Death is an inevitable reality, and there is a bereavement care also. That is what I said. I was preparing to talk about death, and I had to confront a death now, 1 hour before. So this is a reality. If we don't accept that, we are not fit for palliative care. My friend, and who is the person who established Institute of Palliative Medicine in Calicut, Dr. Suresh, told me last time, we are preparing something called Death Cafe. Are you interested? I said, yeah, definitely, because I'm quite sure that I'm going to die. So it is better to prepare earlier on than to say or avoid the word death itself. Right? So this is how the palliative care has become so important now, supportive and palliative care. Where can palliative care be given? Like we can give as outpatient services sometimes. A cancer case which came to us last time, she wanted a denture. So that we could do. This is Dr. Nitin, who works with us ever since we started working. He is preparing a denture for this patient. She is a cancer survivor, as I told earlier. So that is one, outpatient. Then hospital-based inpatient service. Some patients we need to take them to OT and then give them hospital-based treatment. This is Dr. Fazal, who is doing on a patient in the OT. I mean, he wanted to go for endodontic treatment in multiple teeth. So we had to go do it under GA. So that has to be done in a hospital-based. There are standalone palliative care centers or daycare palliative care centers also. We will have to depend on them at times to get things done. And palliative home care, here our team, myself and Dr. Vivek on one side, and we are trying to treat a patient. This person had a fall from the terrace when he was 19-year-old, 18 or 19-year-old, and for the past 30 years, he is bedridden. Now he is almost 50 years, but he is bedridden. And his mother can't move away from him because he needs her all the time. So she had a dentoalveolar abscess. We could treat her in our mobile unit, whereas we treated him on his bed. So this is another case where you have to use palliative home care and also mobile unit. There is no specific guidelines for these kind of treatments. We have to, it is just like a wartime, warlike conditions where we have to decide then and there. We can't get the whole team again to these distant places and then do a treatment plan and all that. So this is about that. This is our outdoor unit. I mean mobile unit where you can see a chair, a place to sit for assistance, doctors. I mean dentist chair, all that. And we take this when we go to treat a group of patients. We try to locate in a place where you need to give attention, healthcare to 3 or 4 people. Then we can take. Then bystanders could be treated there. All right. So now 7 steps to effective communication in palliative therapy. Instead of asking them what is their problem, what is their complaint, we need to build a relationship first. We need to build a relationship and have a very open discussion, because we need to culturally sensitize us. The person who going like, I am a Muslim, I go there, I may be going to treat a patient who is Christian, who has his own value systems. So I may not know, or I am a Malu who is going to treat a patient in Kandla in UP, where I may not even know the local language. So there are a lot of things wherein we have to culturally sensitize ourselves and understand what is going on within the four walls of a home or a house. Then understand the situation. And we can't ask, why can't you take care of your father? Why don't you take care of your mother? It's none of our business. Our issue is to understand what is going on there, and with least interference, let us involve into our business, get into our business, and do give them care. So to give this care, we need to have an open discussion, gather information, and we have to be better listeners than preachers there. We should not we should not preach. We rather should listen actively. Really actively, we have to listen. Then we can understand cultural issues, their medical issues, their family issues, then address the problems. Then understand patient's perspective, what really patient need. Once when we went to went for a home care, patient was looking at a mirror, bedridden, quadriplegic. Then I asked, just commented, nice that you are looking at a mirror. Then she told me, doctor, I'm looking at a mirror because I can't see whether you are coming out from coming into the room or not, because she was looking at the mirror and seeing the reflection of people walking in. That was her way of seeing people, whether they are coming in or going out and all that, to see that. So to understand patient is extremely difficult sometimes. Share information then, what we can do, what we have at our disposal, what limitations we have, and then arrive at an agreement on problems and our plans, and close the discussion sensitive. Silences are important for the patient to, assimilate this, understand this, the whole issue. Sometimes you will have to look for non-verbal cues of communication, because with gestures, they'll try to. Sometimes patient will not be able to talk even. Verbal communication will be nil. So this is how it moves, right? Now, basically, we are trying to do three things. One, we are trying to alleviate pain, reduce pain, how much ever we can. That is one thing. Number two, their only entertainment will sometimes be eating, having food, consuming food. They can't go for a movie. They can't go for, social gatherings. They are restricted to home, and for a movie or for a wedding or for anything. So this patient, definitely one thing they will enjoy, consuming food. That we have to make sure. And third thing is aesthetics. They want to present themselves in a proper manner. So to reduce pain, we can try like routine medications, non-opioid adjuvants and plus or minus adjuvants. And if it is not enough, then we'll have to go for tramadol and all that we say step 2, centrally acting ones, and then moderate opioid for moderate to severe pain, plus step 1. So these are the medications these all and you get these information online as well. So there you have to decide, seeing the pain, we have to alleviate. That is the basic thing. Alleviate pain, reduce pain. Then make them fit to consume food. These are the two things. Otherwise, you will have to give a lot of other medications. Many a times they will have a big chart of medications which they take. Usually we say when they are When they are 50, they will at least have one tablet. When they become 60, they will have more than one tablet. When they become 70, they will have a box full of tablets. This is how it goes. So there will be some cases. Again, this case also is our own case. I'm sorry for the picture, but she wanted one tooth to be extracted, no other treatment. And he also wanted these patients. One was because of sharp tooth. Diagnosis was very late. The other was habit-stricken. These two patients wanted one tooth to be removed, not nothing more. So palliative care in oral cancer, I'm not going into the depths of all that. And what are the problems due to disease per se? This issues are pain, sometimes trismus, they can't open their mouth, and difficulty in swallowing, they can't swallow, and difficulty in chewing, and difficulty in speaking. All this due to disease. These things. Again, then problems following the treatment. Oral physician or a dentist is always they always should look out for a lesion, white lesion, somewhere, anywhere, an ulcer which is not healing for more than 2 weeks. Definitely you should not leave. Last week, there was, not last week, couple of weeks back, 47-year-old lady. For me, 47, 50, all are young because I'm almost 60. So for me, 50 is young. Okay. Like this young lady, and she had a very small nodule kind of thing on ventral surface of her tongue. It was not a nodule even. It looked like an ulcer. It was kind of ambiguous. She was referred from a local doctor. And then we had a look. We treated that ulcer for a few days and there was no change. We went for biopsy and it was, malignant case, but very early. So we could get her referred to as tertiary care center and get it done there. Then once treatment is done, then they come back with mucositis, xerostomia, at times osteoid necrosis, taste loss, altered sensation, of course, candidiasis, nausea, vomiting, all that, trismus again, and multiple dental caries because of secondary to xerostomia. So if they have any systemic issues, that too will add up to that. So that is how comorbidities of oral cancer, these things, how we address these kind of issues. It is extremely difficult. You need to listen to them, talk to them, and then, like we used to have concept of magic mouthwash, and this is to reduce more number of medications to them and treat them topically as much as possible. Like treat mouth sores caused by some forms of chemotherapy or radiation therapy. What we used to do is antibiotics, add antibiotics like anaerobic or aerobic, depends upon that. I mean, see the condition in the oral cavity, antihistaminics or local anesthetics, antifungal, if required, corticosteroids, antacids. Like these are all added. I mean, we ask them to buy all this and then crush and make it a mouthwash kind of thing. Sucralfate, add in sucralfate and then use it as a mouthwash. This does wonders sometimes, this magic mouthwash. But if antifungal is not required, we can remove antifungal. If local anesthetic is not required, we can remove that. But otherwise, you can use whichever is required, that we can use, and we use it as mouthwash. Patient will do it most of the time diligently because they want to get rid of this so that they can have food there. And then another issue is xerostomia. Xerostomia, it is always better to ask them to do frequent sipping of water. Not a big quantity of water, because if they are diabetic, they'll have to go for restrooms again and again. This can be avoided by having a small bottle full of water and just sip and keep it there. Sip once a while, and that is what uh, we can do for them. Otherwise, mouth-wetting agent again will be very expensive. It will be difficult to use. And then you have Silogox that we rarely use. We mostly try to rely upon the frequent sipping of water. That's what we ask them to do. But do a thorough examination always in the oral cavity before we go for treatment, even, I mean, post radiation or post chemo persons I'm talking about. Then in osteoradionecrosis, this is a well accepted one mostly. I mean, we are attached with the hospital, so these kind of things become easier for us, and also dentistry become popular there because they send us such cases and we do send back to. In the beginning, they will not understand the importance of a dentist working on such things. I mean, such patients. I'm sorry. Because once I remember a case where there was severe gum bleeding, and we asked them to go for get a blood picture. Then the blood bank, I mean, my lab professional informed the patient directly that there is some issue, there is malignancy. It was a leukemia case. We could diagnose in the clinic. But then next meeting with them, they told me that we thought you are dentists and you have nothing to do with all this. We said no, we have to we try to diagnose everything. It is not that a person is specialized in something, they will not look at the others. We don't treat it as such. If we have anybody else qualified person there to treat, that is the only thing. So basically what happens is dentistry and mainstream medicine will kind of get bridged, and our importance or our recognition will be much more than before. Like, even in dental colleges, oral pathology will always, Department of Oral Pathology sometimes complain that you don't give importance for oral pathology because we are nowhere. It is not like that. If other departments are working hand in hand with oral pathology and oral medicine as a team, then it becomes the diagnosis and even treatment plan will become much efficient, I should say. So flossing should be discontinued if there is gum bleeding, more than 2 minutes. And brushing, you all know, use an ultra soft toothbrush. I have reached 45 minutes now. Aisha, may continue, or is it okay to continue? Or
Yes.
Yeah, okay.
Yes, sir, yes.
Okay. So another 10 minutes maybe at the most, or less than 10 minutes. I'll conclude.
No, sir, that's no. Yes, sir. Thank you.
Yes. Rinse a brush with hot, with hot water, because disinfectant, because we usually keep the brush there and then use it and we get infected. I mean, especially such cases, we should advise them to minimize chances of infection. Denture, how it should be rinsed. Better than commercial mouthwashes. It is always better to use club soda water, normal saline, sodium bicarbonate solution and all that. And lip, ask them not to wet the lip with their tongue, rather use petroleum jelly or Vaseline jelly or lip balms, so that they will not get a cracked lip again. Because xerostomia cases, mostly persons will wet the lip with their tongue and then it cracks more. It is difficult. Finally, we come to this picture. We are trying to show you what we do and how we cooperate with different groups like ICRA Tunnel Palliative Care Institute, dental NGOs, Dentist and You, how we go to resident care, and then you can save this and you see this, how we are trying to operate. and how and certain dreams of ours are also in this. Okay. Then a little bit about ourselves. Our vice chairman is Dr. Manoj Bengal, and Dr. Arshad is a public health educator. Treasurer is Anwar, who is a businessman and entrepreneur. And then Dr. Vivek, you saw him. Dr. Nitin also, you saw him. Nitin is not in this picture. And Dr. Sherin is also an oral physician. And Dr. Rashid. These are our core. This is our core team. Rashid is an endodontist. So this is about us. I mean, a little bit about our story. We started in 2009. Much before we started thinking about this, we discussed with ICRA International Hospital, Calicut, and used it as a platform. And we set up a dental clinic, and then we went on to set up 2 more dental clinic and a home care unit. That is what we are doing. We call ourselves Dentist and You. It's a registered NGO organization in association of like-minded dental professionals. And we went on to expand our... It's okay. And this is how it is. Now, we, even during COVID time, we were the only one with the government dental college to keep our clinics open for extractions, and most of us got affected or infected with COVID. I was an opener, and then one by one. But at that time, it was like Susan called. It was metaphor. It had become a metaphor. Police used to arrest them if they go out and all that. Now it has become common. So this is about our organization. 2013, we treat mobile dental unit it came in 2015. Treatment options include dental extraction, tooth restoration, scaling, all that. Currently, the service is available in and around Calicut city. And this is our unit, which we take to patients and do treatment there, right? You are seeing our people sitting there. Dr. Vivek sitting there. So we do root canal treatment, removable denture, complete denture, all that. And thank you. I just run down on that. It is 7:50. I'll keep 10 minutes for Q&A. If you have anything, or if you want to add something to this, you can add. I should thank you for listening to me patiently. I don't know how far I could add on to your knowledge and experience with this presentation. Next time, if I am able to come down to Bangalore, I would like to see you in person. That I had told Aisha and Ghazi also last time when I met them. Please, this is about what I have right now. And I am going back to the uncle's place to do all arrangements for his burial tomorrow. So please, Aisha, over to you.
Yes, sir.
Please tell me. Yes, there are some questions. If
Yes,
Aisha
sir.
can
I will
post,
just put on few questions now.
yeah.
So is it audible? Are you
Yeah.
able to hear me?
Yeah, I can hear you.
Okay. So thank you so much for giving us the immense knowledge what you have on the topic. That is really very thing to us at least know as the communication, how we have to go about the patients, the 7 steps what you mentioned, and about the WHO analgesic ladder, what we usually can and have to exactly go with. So now, sir, we have few questions. Dr. Hausia ma'am wants to know how exactly you got into this stream of your practice.
Because I personally had some friends who were instrumental in establishing the Asia's best network of palliative care, Dr. Suresh, Dr. Anil, and Dr. Abdullah. They all were my friends. Suresh is a close friend. Now Anwar Hussain is a director. And they all are friends. So in the beginning itself, while teaching in dental school, we used to treat, we used to take them to students on elective postings to palliative center. early 2000. Then that made us think, why can't we give this treatment by going there? Because we used to see a lot of cases there. They were unable to come to the clinics. They'll come and tell us, look, I have my son who can't come. He is a patient of cerebral palsy. We can't carry him here. So what to do? So we'll say, okay, we'll come and see there. If we need GA something, I mean, again, we'll have to come back. But at least go, you see, and tell them this is the issue. And you can't make them swallow tablets like when they are challenged or special needs. In such cases, we educate them, and then they become friends. And this is how slowly, gradually, we were pulled in, and we're never to get out of that. And we are happy.
Next question. Any book, the name of the book, sir, if you could mention it to at least gain us a knowledge about the palliative care.
I think once I had mentioned about one book, which I always advise is Atul Gawande's Being Mortal. That is a wonderful book to start. Atul Gawande is trained in Harvard. He wrote Being Mortal, book, which is available online, Amazon. Please try to see that, because one has to understand geriatrics a little bit so that we can go for this terminally ill and even otherwise. So right now, I would advise that book to begin with.
Okay, sir. So any palliative courses available for the students as of now?
Yes. Calicut Institute of Palliative Medicine is conducting a program. If those who are personally interested, I mean, if anybody is interested, I can direct them to them. I mean, the Institute of Palliative Medicine in Calicut. Short-term courses are available, so people can do it, and it is very useful. It is a very well-established center, so their training is good enough.
So can you share us a link on the group, sir? If this particular link, if you can share us on the group.
Okay, right now or later?
Later on, sir.
Yes,
Later.
yes.
So then we have question is, any pediatric oral palliative care, is it available?
Pediatric oral palliative care. Early intervention center is working, but not with us right now. But we can think of that. We have we have an early intervention center here. They are looking into this now. It is a recent development in Calicut itself, very close to our hospital. It is under our management itself. So definitely, if particular cases are got or communicated with us, if they can communicate with us, we can see. I think we should discuss. Then certain cases can be done in Bangalore itself. Otherwise, coming to Calicut from Bangalore seems, I don't know. I mean, it depends on cases, because every case is different. That is the problem here. So we have to individually see the case and then address the case in pediatrics, especially. Let us see that we are ready to cooperate.
Okay. So we have question from Dr. Rajshri. Is there any fixed combination for ingredients of magic mouthwash?
There is no fixed combination. If patient says there is severe burning sensation, like in lichen planus, if patient says severe burning sensation, then we have to use lignocaine gel. But lignocaine gel is very bitter, very bitter. So their sucralfate will help to change the taste. Like Metrogel, if you are adding it again, its taste is little difficult to patient to use as mouthwash. So such things you can add something. There is no fixed constituents for magic mouthwash. We call it magic because we add different ones as per the requirement and give them. So that is how we do this, Rajeshri.
So any exact dose of the magic mouthwash?
No. There is no exact dose. It is only topical, right? So we ask them to use 3 times daily. And if there is steroid in that, then we'll ask them to taper it down.
So we have another question from Dr. Ghazala. How about photobiomodulation therapy for
Yes.
post-chemo, post-radiation, and post-radiation therapy mucositis?
We haven't tried as yet. So I'm unaware that whether we can use it or not. We haven't used it yet. So I thank you for that question. I will refer back and then get back to you.
Yes, sir. They would just want to know about the facilities if anything is available in India also, sir.
Oh, sure.
So next we have a question from Dr. Rashi. Any side effects of pilocarpine?
Yeah, there are. So that is why we are not into using pilocarpine. If my memory is right, I have used only once because it was very severe. So otherwise, we don't go for pilocarpine.
So is Civimilin available in India? And if yes, what is the brand name?
That is Vivek. Are you there, Dr. Vivek?
So
Dr. Vivek,
Hello. Yes, sir. Hello.
could you please answer this?
Yes. So the brand name is Exovac. Exovac. The brand name is Exovac. EVOXAC. Evosac. Sorry, not Exovac. Evosac. Cevimeline is when compared to pilocarpine has got lesser side effects. All of the side effects are basically constitutional side effects like the nausea, vomiting, and all that.
Sir, is hydrogen peroxide at low concentration used for oral mucosa? Is it friendly?
No, in low concentration, it is fine. There is no problem.
Okay. Can it be used for patients with head and neck malignancies?
Again, hydrogen peroxide?
Yes, sir.
Yes.
Sir, can dental extractions be done safely at home?
Definitely, yes. We have been doing this for years together now, but we see all the conditions, and we also see locally accessible doctor for them. I mean, medical doctor for them. I mean, for them to discuss, and we see their medical history properly.
Sir,
Their drug history also.
okay.
Then
So
only we decide.
Evoxac the dosage, sir? Civimilin.
Yeah, it is available. Yes.
So Dr. Hosia wants to know from Kerala to UP, how exactly this happened?
That is because a friend of ours was running a school there. So he asked us, they were going for a polyclinic there. We visited that place. Then we thought, okay, because we had facilities there. Because logistics was easier for us because once we reached there, things were easy. So we tried there. We tried in Bangalore once, but it hasn't worked yet. We have requests from Bangalore, Tamil Nadu, Bihar, West Bengal, all that. But we are such a small team, we can't think of all that right now. We are thinking of only 3 clinics, 1 mobile unit. And but our dreams are big. We can go anywhere, Gausia, if we have support, local support.
Yes, I take
Local support in UP.
Yeah, thank you, sir.
Right.
Hello. Hello.
Am
Yes.
I audible, ma'am? I think I have few more questions, ma'am.
Yes,
Hello.
yeah. I think Dr. Ghazala wanted to know about photomodulation. I'm sorry, sir. I'm taking this time in the difficult time, but there are a lot of queries and a lot of attendees for your presentation. So, Dr. Aisha, some photomodulation question from Dr. Ghazala. If you can unmute yourself and ask Dr. Ghazala.
Dr. Ghazala?
Hello.
Hello, yes.
Hello, I am Dr. Rajashree. I am a consultant in palliative medicine.
Yes.
Pilocarpine
Yes.
when we can use the 1% ophthalmic solution, it is devoid of much complications.
Yes.
So we can use 2 to 3 drops thrice daily or BD, depending on the need of the patient. That is
Right.
devoid of many side effects of pilocarpine when it is used at a higher dose.
Right.
So
Thank
that
you.
is what we use.
Thank you.
Thank
Thanks
you.
so much.
Hello.
Yes.
Dr. Ghazala?
Yes, Dr. Gazala here. Hello, sir.
Yes.
Thank you for the lovely presentation, and it's been very inspiring to hear you. I am very happy that Ahsan has been established in Calcutta, if I'm not wrong. And I wanted to know if any such centers are going to be established in Bangalore.
We tried, but we are open.
My question was about photobiomodulation. I've been using lasers to treat oral mucositis.
Yeah. Yeah, true. But again, these are we try to avoid um, expensive. I mean, when I say you might ask, I mean, that will give respite to the patient. That is right. But we are trying to do with a minimal budget. So we haven't tried, I mean, lasers also. So I'm not the right person to comment, because I have been discussing with people, but even ulcerations, it will be very transitory kind of effect it has, and literature also say that. So I can't comment on that. Vivek, do you have anything to say on this, Dr. Vivek?
Yes, sir. Low-level laser therapy, say LLLP.
Yes.
I think she said she was using, so she might know better than us.
Yeah.
So that can be used, as you said, for oral
I've been using
mucosiliation.
a couple of cases now, and if we have a proper protocol,
Yeah.
radiation, immediately after radiation,
Okay.
post
Yes.
radiation,
Yeah.
considerably reduces the post and radiotherapy induced, and
Okay.
therefore the eating ability of the patient is better. But the problem is not many doctors are very convinced with dentists doing their part for the oral mucosa, so they're not very
Yes.
convinced that it can make a difference. So I wanted to know if you know any centers which are already, or if there are patients that you could refer, because we have a laser unit and we are very happy to do
Yeah.
things for the patient.
Yeah.
Okay. Thank you.
So next question is, are you open to train the young dentists interested? Like you mentioned, conventional chair positions to modified positions, what do we use?
Yeah, we have been training many. I mean, around more than 55 dentists we have trained. I think, as I am not very sure about the number, but more than 50. So then we stopped because of our, recently we stopped because of our limitations with our space and such constraints. We are going to start again. Definitely.
I don't think we have any more questions, sir. So please
Yes.
do share us the link about the courses, whatever has been happening on the group later on at your time.
Yes.
And ma'am, do we have any other queries, ma'am?
I think Dr. Basha's, most of the patients complain of taste changes. How can we help them? I think Dr. Basha was asking this.
Here again, that depends. I mean, it becomes like talking to them. Sometimes it is impossible to do anything for them many a times, but some cases you will be able to help them out by looking at, more, in some cases we are able to help them out. Other cases like neurological issues, difficult. Some cases it will be candidiasis, some cases it will be, it has to be, as I told you before, one has to see it, treat it according to the merit. Every case is different, really different in these kind of, lot of medications are taken, so a lot of modifications occur there, a lot of interaction occur there, so you have to discuss with the patient, discuss with the physician, and then only we can do. I no magic solution at all in here.
Yeah,
Hello.
Yes.
What is the dose of that Evoxac 7 million? Could you just post it, sir?
Dr. Vivek, please, will you please post that dosage of
Yeah.
medication?
Yes, I had posted it as 30 milligram thrice daily.
Okay. Thank you, Dr. Vivek, for the help.
Yes, sir.
Yes.
I don't think we have any more questions, sir. Dr. Gaussia, ma'am,
It's only gratefulness to sir for all the, I mean, sir, if you could have told us, you know, the condition you were in, we could have always rescheduled the meeting. But nevertheless, we had a good, you know, good learning session. And of course, your model itself is a very inspiring model. I would definitely look forward to emulating it and letting our juniors also take forward, like as we discussed in the first meet. And thank you again, sir, despite the adversity you had come over. Yeah, thank you. Thank you, sir.
Thank you so much.
Thank you, team.